So the third abstract that I have the pleasure of discussing in the session is from Dan Zandberg, which is a study randomizing patients between the immune checkpoint blocker Avelumab, which is an anti-PD-L1 targeted agent, with Cetuximab or not with Cetuximab. So it's Avelumab Cetuximab versus Avelumab as a single agent therapy. Relatively small number of patients in this randomized phase 2 study. And what the data show is that there is a difference in favor of the patients who receive the doublet treatment, suggesting that Avelumab, which belongs to the immune checkpoint class and therefore we know potentially has activity in cutaneous squamous carcinoma, can be added to in terms of its benefit by giving an anti-EGFR targeted therapy. The striking finding in this clinical trial, however, is that the single agent Avelumab arm performed really rather poorly compared to historical controls. And if one looks at the median progression-free survival data for the patients in the doublet arm of the treatment, one doesn't see that it's very much better than the sort of historical controls that we see, especially for Cemiplimab as a single agent, or indeed for Pembrolizumab. So it really raises the question, is the addition of Cetuximab really bringing anything that is going to deliver benefit for patients? We don't know that from these studies. The underperformance of the Avelumab arm leaves us with significant doubts. I think in particular, my take from this data set is that EGFR blockade, potentially with immune checkpoint blockade, may be a very interesting way to go. I think there are differences in terms of the designs that we might look at. We may choose to use a PD-1 targeted drug such as Cemiplimab or Pembrolizumab. And also there are now novel EGFR targeted therapies, notably the agents such as Petosemtamab, a bispecific that targets both EGFR and LGR5, but also the Ficerafusp alpha agent, which targets EGFR, but also has the ability to trap TGF-beta out of the tumor microenvironment and promote anti-tumor immunity. So I think this is an area that will deserve further evaluation. I do not believe that these data necessarily suggest that Avelumab plus Cetuximab is the natural choice for any subsequent phase 3 trial.